So, good afternoon, everyone,
Good afternoon.
and thank you for your patience as well. Sorry, I was in clinic this morning on the east side of Madison.
Thank you
Okay.
for making it.
So today we'll just talk about an overview of memory loss. What does memory loss look like as we get older and wiser? And so once again, I'm Dr. Shenikqua Bouges. I'm an assistant professor at UW as well as the Madison VA in our memory diagnostic clinics. And so today, just first we'll start off by going over some questions just for you to think about, because at the end we'll discuss those questions again, and I should cover most of those questions throughout the discussion. Goals for today's discussion, I'll put up a slide to go over that. Just some common terms you may hear me use throughout our discussion, as well as changes that occur with aging. That's with normal aging, as well as when individuals are having some abnormal changes with aging. And then an overview of Alzheimer's disease. So these are the questions to think about as we have our discussion today. Is Alzheimer's disease the same as dementia? Because I get this question a lot. Is dementia reversible? Are there any treatments for dementia? We hear a lot about Prevagen, because Prevagen has a lot of commercials saying it's good for memory loss. And is there anything that can be done to reduce your risk for Alzheimer's disease? And then just a general question to think about when asking, how do you rate your health? Poor, fair, or good? And I'll tell you why I asked that question at the end. Okay, so we'll go over a general understanding of dementia, overview of risk factors, as well as some treatment options that are out there. And the goal is to provide this information so you continue to advocate for yourself and friends who you may see having changes with their memory. So common terms. Cognition is basically the way we think, perceive, and understand information. That could be with our memory, how we learn information, attention, language, just how we interpret information. When talking about independence, I put functional independence because this relates to our instrumental activities of daily living, which is more of those complex day-to-day activities like managing finances, medications, driving, as well as your basic activities of daily living, because this is what we use when trying to classify if someone meets the criteria for mild cognitive impairment versus dementia. And so with dementia is just an umbrella term that describes a group of diseases that impact our thinking and learning abilities. And so Alzheimer's disease is a type of dementia. So it fits under that umbrella, and we'll talk about that more as well. So normal changes that occur with aging, as we all age and get wiser, you expect things to gradually slow down. That's our thinking abilities, how we process information, interpret information. With normal aging, we all forget from time to time. The key distinguishing factor is someone who's not forgetting pretty frequently to a point where it's impacting that individual's ability to carry out their day-to-day activities. We may occasionally misplace our keys, but we'll find them. Possibly forget what we put in a recipe. And so when these changes are happening with aging, one good thing to do is also consider what's going on when those changes are occurring, because some individuals may be a little bit more forgetful because they're stressed. Stress will definitely impact how much information you're able to retain. But one key thing to keep in mind is your wisdom and creativity is maintained as you age. And so some of those abnormal changes that occur with aging is when someone is starting to forget a little bit more than their typical baseline, or someone who's more repetitive, so asking the same questions multiple times or making the same statements just because they can't recall previously asking that information. are sharing that information. This is someone who's starting to have a little bit more difficulties with problem solving as well. So having trouble with forgetting what ingredients go into your favorite recipe, someone who's starting to struggle with medication management, forgetting to pay bills on time, missing medical appointments, just those common day-to-day activities that you do and become a regular routine. You start to struggle with it. And so when going into those abnormal changes that occur with our thinking abilities, we'll first start with mild cognitive impairment. So this is someone who notices a change in their thinking abilities, or maybe a family member or friend will notice those changes. And these changes are happening a little bit more often. And then also you would see those changes on objectively, and that would be through a cognitive screen, or if someone was to come and get formal memory testing, or we say neuropsychological testing. But these individuals are still able to compensate despite having that memory loss. So meaning you may forget what today's date is, but you're still able to look at your phone or your watch or calendar or take notes to help you remember what day it is, or using a weekly pill box to go back and see, did I take my medication yet? So they're compensating well. As opposed to someone who has dementia, so this is a change in cognition, or our thinking abilities that declines from baseline. With these individuals, you have those objective measures, so some difficulties in memory, attention, or language that you see on a cognitive screen or testing once again, but also these changes are more progressive to the point where it impacts that individual's ability to carry out their day-to-day activities. So this is someone who's now starting to forget to take their medication every day, or starting to get lost driving to familiar locations, or having accidents, or veering into someone else's lane. That's when it's concerning for dementia. And so this just summarizes, or put those two forms of cognitive impairment together. And so the image on the bottom is showing you how things progress with memory loss, where you see, thinking of a tree with a bunch of green leaves, and as individuals lose brain cells a lot more advanced than what you would expect for their age, the color of the leaves change, and then you have more leaves falling off of the tree. So with mild cognitive impairment, yes, you have some brain cell loss that's more advanced than what you would expect for that individual's age, but they're still compensating pretty well, able to carry out their day-to-day activities, as opposed to someone who meets the criteria for dementia. So just want to put this into perspective. So we'll use Betsy, just a made-up name. And so Betsy is a very active church-going 75-year-old individual. She assists with the care of her grandchildren, and she's still working part-time 2 to 3 days a week. She continues to take her grandson's tithing checks to church for him while he's away at college. However, as the years continue to progress, Betsy's grandson, who's now in graduate school, notices his tithing checks haven't been processed for several months. Betsy can't remember if she paid his tithes, and she's unable to locate any of his missing checks. With the assistance of Betsy's daughter, they're able to find the missing checks several months later. Betsy is also starting to forget to pay her tithes and has been missing church services. So just to highlight some things from Betsy's case, I highlighted her age because you're 65 years of age and older, your risk for getting Alzheimer's disease increases. And so Betsy is 75. What's concerning with her particular case is she's now forgetting to pay her grandson's tithes in church, which is something she does regularly. So that highlights the point that she's now unable to compensate and even remember that she's paying her grandson's tithes. And she's likely misplacing the checks because she couldn't find them. Another key feature with Betsy is she's starting to miss her church services, and that's something she likely enjoys because she's a very active church-going individual. So that means Betsy is likely struggling to the point where she may be in the dementia range. Or it would also be good to get a good history for Betsy to know if anything is complicating her clinical picture, because if she's forgetting to take her medication, that will impact her ability to recall, to pay the tithes, and go to church on time. Oh, I just highlighted 4 years later, also to show the time frame where she's about 79 to 80 years of age, which is important to know as well, because your risk for Alzheimer's disease increases with age, but then you can have multiple causes as you get older and wiser as well. Thank, thank you. And so I just put up dementia again, so we include Betsy's information in there. So she was having those subjective changes where she's forgetting to pay tithes. She's disoriented to the day of the week because she's forgetting to go to church on time. We don't have any objective measures in that particular case, but that would be needed in order to come up with a formal diagnosis for her. And we know that these cognitive changes are starting to impact her day-to-day activities. So with financial management as well as appointment management. Okay, so Alzheimer's disease, a little bit about Alzheimer's disease. So Alzheimer's disease is the most common type of dementia. 2024, it was the sixth leading cause of death. It's estimated based on clinical symptoms. So these are individuals presenting to clinic with symptoms concerning for Alzheimer's disease, that about 7.4 million individuals 65 years of age and older have Alzheimer's disease. And this graph shows that your risk increases as you get older and wiser. I highlight the point that this is based on clinical symptoms because now with the advancement in treatment and research, based on autopsy and clinical biomarkers, that percentage of individuals or prevalence is 15 to 30% less. And so that would be more of a definitive diagnosis because when you use the biomarkers, that's going to be positive for Alzheimer's disease, but also autopsy or a brain autopsy is the most definitive diagnosis because they're actually testing the brain cells or the brain tissue to check for Alzheimer's disease. So some risk factors for Alzheimer's disease, I broke it down into non-modifiable versus modifiable risk factors. So things which you and I have no control over are our genetics, age, which is the greatest risk factor, and then family history can increase your risk for Alzheimer's disease. But you can't definitively say that if someone has a family history of Alzheimer's disease that that individual will develop dementia later on in life because lifestyle habits factor in as well. So history is important. When thinking about modifiable risk factors, vascular risk factors play a huge part. And so that would be like your hypertension, high cholesterol, sleep apnea is a vascular risk factor, diabetes, any tobacco use, traumatic brain injury can increase your risk, and it's the repetitive injury because that's damage to your brain cells. Mood disorder, so anyone with anxiety or depression is not well controlled because that can cause a pseudo type of dementia. But the good part is with a mood disorder, if that's the only contributor to the cognitive changes, that would be reversible if you treat the mood disorder. Air pollution has been shown to contribute to cognitive decline. Lifestyle habits, sensory, that's vision loss or hearing loss, can impact how much information you retain as well as sleep. And so this particular slide is showing the changes that occur with Alzheimer's disease. So on this side, this is showing a healthy nerve cell. And then this side that the cursor is moving is showing you an abnormal cell. And so what it's showing is what happens is we have amyloid plaques that build up in the brain. And so it builds up in the brain due to an abnormal process if that protein isn't clipped in the right spot. And so then it produces an accumulation of these amyloid plaques, which destroy the nerve cell. And that's what creates damage, but then also leads to an increase of tangles within the nerve, which also disrupts the communication between two nerve cells. So on this opposite side, where it's showing you the brain and putting it more in perspective from a larger picture, you're seeing a brain without any significant brain cell loss or atrophy compared to one impacted by Alzheimer's disease. And they highlight, so the areas that we look at a lot when thinking about memory loss is this temporal lobe tends to be pathognomonic for Alzheimer's disease. So your hippocampi, which sit in this area, is some significant atrophy or brain cell loss. You can tell where you see a lot of space on this side compared to this brain that's more compact. And so this puts it into perspective, looking at an MRI, so taking a picture of someone's brain. And usually you don't see a significant amount of atrophy on individuals' brain. It's just depending on how progressed that individual is. It's usually harder to see this significant atrophy in some individuals, but showing you a healthy control versus someone who has Alzheimer's disease, so they have a lot more advanced atrophy of brain cell loss, so you see a lot more space for this particular picture, because the brain should take up most of your skull. But here you can see it's a significant amount of space here in your temporal lobe region. And then the hippocampi, which is responsible for memory, is reduced, which is highlighted in this area. And these are areas we look at when trying to assess for concerns for Alzheimer's disease. Some of the changes. And so this graph here is showing you the progression of Alzheimer's disease. And the purpose of showing you this is because usually by the time we see someone in clinic presenting with mild cognitive impairment or dementia, they're all the way down here on this graph. However, but thanks to research, we're able to detect changes concerning for Alzheimer's disease a lot sooner in the disease process, or they call it the preclinical phase, because typically they say that individuals already have that accumulation of the amyloid plaques in the tau protein 15 to 20 years before we see them in clinic. And I'm highlighting this because of some of those advances that we've made thanks to research so this purple line is the first indicator of the amyloid plaques that you can detect from the cerebrospinal fluid. So that's a lumbar puncture, which is a little more invasive. So not a lot of people are agreeable to having that done. And then the amyloid PET scan will be positive. It's a type of imaging that specifically looks for amyloid plaques in the brain. Is the next line you see, followed by that tau protein in the cerebrospinal fluid, and then MRI and the FDG PET scan, which is another type of imaging study that specifically looks at glucose metabolism. I'll show you more about that a little later on, but this was the only type of imaging we initially had in clinic to identify changes for Alzheimer's disease, so it wasn't helping us detect it any earlier. And so how is dementia diagnosed? So typically you will have someone presenting to their primary care provider. Sometimes a specialist will pick it up if it's someone who's starting to struggle with keeping track of patient instructions or medication management. You do a cognitive screen to see if it's anything concerning on that cognitive screen. A detailed history and physical exam is very important, as well as labs and imaging studies to help rule out any reversible causes. If it's anything concerning, or if it's someone who has a significant family history, despite scoring in the normal range on a cognitive screen, they may benefit from further or formal neuropsych testing as well, just to get a baseline. And so they would be referred to a specialty clinic for that formal workup. And so with that workup, so at our particular clinic, we have a process where individuals will first go through a triage clinic. And in that clinic, we do a cognitive screen and try to rule out any reversible causes. So getting labs that need to be done, any additional imaging that helps us in that workup before doing the formal testing. And just so you have an idea, when someone says we'll refer you to memory clinic, when you come to memory clinic, those tend to be longer visits. So we say plan for about 3 hours because you're testing from an hour to an hour and a half, depending on how long it takes you to get through the questions. It's a social worker, so it's an interdisciplinary team approach. So a social worker speaking with family member or friend to get additional history, then you meet with a geriatrician to go over the results and everything. And so I brought this graph up again just to highlight some of the advancements that we've made. So now we do have a blood test that can detect a biomarker for Alzheimer's disease, so the amyloid plaques that helps us detect changes a little sooner than someone on the green line. And then also now we're able to provide amyloid PET scans in clinic, not just on the research side. And so this has been in the articles, well, in the news, where they had Lumi Post G was the blood test that was approved by the FDA as the first blood test for Alzheimer's disease, where this one is looking at your phosphorylated, so the tau protein, as well as your amyloid beta. Is looking at the ratio to help detect changes concerning for Alzheimer's disease. We don't use that particular blood test, but we use Mayo Clinic's blood test that looks specifically at the phosphorylated tau. That test, we have a quicker turnaround with when you receive the result, and insurance covers that particular lab. That's why we chose the Mayo Clinic lab. And it has a high specificity as well as sensitivity. So high probability where the results correlate. So a positive blood test correlates with positive amyloid PET scan, and a high percentage where if you have a negative blood test, then you have at least like a 92% chance that that's actually a negative amyloid PET scan as well. So just going over some imaging changes that you would see. And so when I was talking about the different imaging studies, so on the clinical side, we're fortunate now to be able to provide an amyloid PET scan, as well as we have the FDG PET scan. And so the names in front of the PET scan is just telling you what you're looking for. So with the FDG, that's just, it's looking at glucose metabolism. And the acronym is just talking about the type of glucose, fluorodeoxyglucose. So we just use FDG. So that one is looking at glucose metabolism, and it helps us distinguish the different types of dementia based on the amount of atrophy or brain cell loss someone has. As opposed to amyloid PET scan, you're specifically looking for amyloid plaques in the brain. And then tau is that other downstream product from degradation or nerve cell damage. And you're specifically looking for tau on the PET scan. And this just shows you a brain in someone without memory loss versus what the imaging study would look like in someone who has Alzheimer's disease. And so with this one, so they say structural MRI. They just highlight it as blue, but like the MRI we showed earlier, that person will have a lot more shrinkage or brain cell loss in areas classic for Alzheimer's disease. On a PET scan, red is good. So where you see decreased red,
I have a question about the brain. Are the brain cells for a 70 or 80, 75-year-old or 80-year-old? They show a normal healthy brain, but they don't give me the age of the brain.
Is that age?
right. This is not putting it in perspective for the age. However, when we do imaging, they do put it in regards to that individual's age. And then now, so with our MRI, they have software which gives you a combinostics report, so it calculates the amount of atrophy in reference to your age. Also looks for a significant amount of vascular disease. So they'll calculate a score for you and tell you how much hippocampal atrophy, how much cortical atrophy that individual has, and they also give you a probability score that that individual may have Alzheimer's disease. Thank you for asking that question as well. So yeah, we do compare it to your age group. And also with that software, it'll show you that individual's brain, and based on the changes on that brain, they estimate what your age is. So some people, even though you're 89, they have brains that look like an 80-year-old or 79-year-old. So they calculate that as well.
At what age are these tests available? I mean, if you show mild cognitive disorder, will they run you through this series of tests, or do you have to have a fairly severe case before they?
Talking about the imaging studies?
Yes.
So when we're working you up, if you meet the criteria for mild cognitive impairment, you would get these imaging studies. It also depends on treatment. So if we're trying to see if you would be a candidate for the newer medications, the monoclonal antibodies, we do that extensive workup. So that would be the blood test, so checking that biomarker, and more specific imaging as well, specifically the amyloid PET scan, because you have to show positive amyloid plaques before you could be considered for the medication.
I'm just thinking, like in a family history, at what age the children should try to get some kind of testing done, and something more. I mean, I would think that the genetic aspect of it would allow you to be tested sooner, but I don't know.
Will you be here to the end of the discussion? Okay, so I'll highlight that for you. Great question as well. Okay, so then this is just showing you examples of how it looked with those different type of imaging studies. So this one is looking at glucose metabolism, and it's showing you that this individual definitely has a significant amount of hippocampal atrophy, both sides. And then on imaging, they have decreased red or decreased metabolism in areas that would be pathognomonic. Here they're showing you a different area of the brain that we look at. You can't appreciate it as much on this particular cut because it's a different view, coronal versus axial, but it's just showing you. So with the posterior cingulate gyrus, that's another area we look for decreased metabolism or atrophy for when we're concerned with Alzheimer's disease. And this is just showing you the amyloid PET scan, how it looks in someone who doesn't have Alzheimer's disease versus someone who does. And so this one with the color intensity is different. Increased red is not good. That's a lot of amyloid plaques.
What's the +6, +10 number mean?
That may be the year. So when they follow them over time, 6 years, 10 years. In comparison, so you would expect to see as you see things are progressing, a lot more red that's occurring. With this one, this number is the scale that they're looking for. So red is worse. So this is a negative PET scan versus a positive tau PET scan. And this just puts it all together for you. Looking at someone without any Alzheimer's disease versus Alzheimer's disease with the positive amyloid PET scan, positive tau PET scan, and then a positive FDG PET scan where you have decreased red here. The other two increased red is positive. And it's showing you when you're thinking about a differential diagnosis, especially when working someone up, the most definitive confirmatory imaging study is the tau PET scan because it's indicative of downstream degeneration or damage to the nerve cells. So treatment options. I broke treatment options up into non-pharmacological approaches versus medication. So when thinking about non-pharmacological approaches, key is treating any modifiable risk factor. So definitely if it's a concern for vascular disease, hearing loss, vision loss are common. If it's a concern for sleep apnea, mood disorder, you definitely want to make sure that individual is optimized medically. Thyroid disease is common as well. Exercise, typically recommend 2.5 hours of moderate intensity exercise. So running, walking at a moderate pace where you can't comfortably carry on a conversation, or doing some chair exercises where you're getting some strengthening exercises in. Sleep, aiming for about 7 to 9 hours of sleep is recommended because sleeping is when your brain is able to recover and get rid of some of those bad toxins. Diet, we stress the MIND diet. So the MIND diet is a combination of your Mediterranean and DASH diet. So that's eating foods like your extra green leafy vegetables. Berries have been shown to be beneficial. Whole grain products, mixed nuts, trying to limit your intake of red meat.
Pastries.
Stop it. All the things that I like to do.
Socialization is very good because it helps you continue to stimulate your brain as well as playing games, reading, learning a new language or new skill tends to be very challenging as well. I also made some copies of the MIND diet, brain healthy strategies. If anyone would be interested, I'll take it out for you.
So-
I have a question or a comment. When you mentioned exercise, and I think you said 2 to 2.5 hours, that's a weekly.
A week,
right?
yes, a
Not
week.
daily. Okay.
Not, oh, I'm sorry, not daily. So you, yeah, because ideally they say 25 to 30 minutes, like 5 days a week, but you may want to do a longer duration, so that will shorten your days of the week. So 2.5 hours per week. Medications. So with medications, the oral medications have been out for several years. Donepezil was approved in 1996. And so these were the oral medications that have been out for several years. They treat symptoms. They're not going to stop what's going on. But overall, they're helping to keep that message around longer between the nerve receptors. The acetylcholinesterase inhibitors, that's Donepezil is a common one we typically start with. Rivastigmine, galantamine, they're all in that same class. And then if someone can't tolerate the acetylcholinesterase inhibitors, we go to memantine, which acts through a different pathway. Typically, ideally, if someone can tolerate both of the medications, you start the acetylcholinesterase inhibitors first because they're FDA approved for all stages of cognitive impairment. Then memantine is typically approved for moderate to severe stage dementia. But you can use it earlier if someone can't tolerate acetylcholinesterase inhibitors. And that would be due to heart rate being too low, if someone has significant GI concerns already, because it can cause a lot of upset stomach. And so the newer medications, which we have now, are the anti-amyloid therapies. And so they've made progress with these because now you're acting a little bit more direct in that process where they're targeting those amyloid plaques that are building up around the normal nerve cell, causing damage. So these medications are binding to this to stop those prevent those amyloid plaques from affecting the nerve cells. And so we have 2 medications now that's FDA approved. They initially started with aducanumab, but aducanumab had to be removed prematurely just due to the adverse side effects where it was an increased risk of brain bleeds. With that medication. You still have that risk with these medications, but they've made a lot of modifications to help lower that risk. And that's why it's a strict inclusion criteria when trying to see who would qualify for these medications. So that's been a challenge. A good bit of individuals, sometimes it's not safe to start them on these medications because of the potential side effect. And that would be someone who has a significant amount of vascular disease or injury to the vessels in their brain, someone who's on a blood thinner. It would definitely be contraindicated. Or if you're on like immunosuppressives, it's definitely contraindicated. These are infusions, meaning you have to come in and have the medication administered through your vein as well. So it is a commitment where lecanemab is a bi-weekly infusion, and then donanemab is a newer anti-amyloid therapy, which is a monthly infusion. And then the commitment with these medications is you have to be monitored pretty regularly because of the concern with the side effect, where you have to get an MRI of your brain between certain doses of the medication just to make sure there's no concerns. And then also, oh, I'll tell you on this slide. So we talked about the infusions and the regular brain imaging, and then who this medication is for. So the medication is indicated for individuals who have mild cognitive impairment or mild stage dementia, not progressive stage dementia, because the medication is not reversing memory loss. The goal is to try to help delay that progression even further. So you want to start it as early as possible. With this medication, it is expensive. That was a question I got previously. So Medicare has agreed to cover the cost of the medication, but that's if individuals agree to be a part of their registry so they can monitor you throughout the course of the medication. But it is still a 20% co-insurance that you will incur those charges as well, which can be anywhere from $5,000 to $6,000 over the course of a year if you don't have a supplemental insurance that kicks in and help with the medication. So transitioning, still talking about treatment, but some of the claims that's out there. So Prevagen is a big one where I get a lot of questions asking if Prevagen will help prevent memory loss. They hadn't found any reliable data with Prevagen reducing memory loss. We don't have a cure for Alzheimer's disease, not at this time. And so then FDA, it wasn't even FDA approved from the dietary supplemental pre-market. So that screening they go through to see if it's a safe supplement for an individual. So we really don't know how serious the drug-to-drug interactions are with this supplement either. So would not typically recommend Prevagen for individuals because they don't have, when you're thinking about a medication and how safe it will be for the population, you want to make sure you have an extensive clinical trial. So with a large sample size before taking it out to the general population as well. And their study wasn't with a large sample size. They had 218 adults. And that study wasn't definitive, and then it wasn't reproducible, which was concerning.
What is the Madison memory?
That was the study. The Madison memory study came up. Yep, it was. Not at the UW, private industry.
And what was the age group of the people who were in this test?
40 to 91 years of age. Self-reported memory concerns.
Okay. So honey is another one we're hearing a lot more about. And the concern with this is too, with a lot of the ads, they're targeting older populations, and now they're using famous people to promote these supplements. I think one, they're using Bill Gates to say that honey is good to help with memory loss, but if you look online, I don't think Bill Gates is endorsing it. They are doing clinical trials on honey because honey does have great benefits. Honey is an antioxidant, which is good, has been shown to be neuroprotective, but the challenge is until you do an extensive study on a large sample size, we don't know the effective concentration to use to really get that neural protection in adults. So wouldn't promote honey as saying it cures Alzheimer's disease. So back to the...
They're recommending that you just add that to your coffee. And you could get a sizable amount of that honey in there, but then that goes with coffee and gets throughout the body.
Mm-hmm. And so that was the other challenge when researching with honey. So one challenge they mention is you have several different types of honey. And they come from different geographical locations, and depending on where they come from, the benefits are different. So it's, I think they call it the phenolics, which are what gives honey its anti-inflammatory property. So you don't know which type of honey to use because it's different types of honey. So you could say honey A has all of these benefits, but if someone purchases honey C, you can't definitively say they have the same properties because they come from different geographical locations and the benefit is different. But then also, we don't know the effective concentration to use for honey where you really appreciate that benefit, and they say it just may be too high of a concentration that you need to really appreciate that benefit. So that's the challenge as well.
So are there any medical institutions doing any legit studies on this?
Honey,
Manuka honey, they say?
Yeah, they say Manuka honey. It is a researcher. I don't remember his name right now, but it do have a researcher who's working on some clinical trials. Not here. Not at UW. We're not doing studies on honey. Not currently.
You can look it up under Mayo and Cleveland Clinic.
thank you.
Are you aware of any studies at all using psilocybin or hallucinogenics for brain degeneration?
Yes, I had a patient that asked me about that as well. I had a patient ask me about that. We don't necessarily recommend it because you have to be careful as well, because with hallucinogenics, you have to think about the cognitive side effects. Even some individuals are using lower concentrations of lithium orotate to help with memory loss as well. And it's a very low concentration, so you don't know how much of a benefit you're getting from that medication.
VA was doing the study.
Yeah.
The VA was doing the study. Okay. They did that study because they were talking about PTSD.
Yeah, they're talking about using it in many
That's different.
aspects.
Which lithium helps with mood disorders. So you want mood to be optimized, but when thinking about some of these supplements or treatments specifically for memory, it may not be as beneficial. But you definitely want to make sure mood is optimized, because PTSD can complicate things that's going on with memory loss as well. Okay, so back to those questions. I think is Alzheimer's the same as dementia?
It's one of the medical, it's under the umbrella of dementia.
Yes, umbrella.
Yep. And do you believe dementia is reversible? That's a tricky question.
Yeah, it is.
Take up something new, that you're not relying on the past. But we are progressing very, very quickly in all manners of science. If you take something new and then you're trying to learn it, what you're actually doing is rebuilding the brain. So when you do that, then the brain has a new activity and it has the curiosity it wants to know. So on its own, it starts progressing.
Well, that's good news.
I agree. And so is dementia reversible? That's a tricky question. If we were specifically saying, is Alzheimer's disease reversible, I would say no. But if someone has pseudo dementia due to like severe depression or severe anxiety, that would be reversible. But I didn't say pseudo dementia either. But it's just understanding the type of what's causing those symptoms. Because some individuals can meet the criteria for dementia because they're just severely depressed. So that impacts their ability to manage medication, get up and go to appointments or do anything.
What about improving your vascular health?
So improving your vascular health, that's a great question. So with vascular disease, because you can't have a vascular type of dementia, that's more of a stair-step process. So with vascular disease, we don't expect things to continue to gradually progress and decline like Alzheimer's disease. You can stay steady in that mild cognitive impairment for the rest of your life with vascular disease. So not necessarily reversing the damage, but maintaining. Will Prevagen treat dementia?
No.
Is there anything that can be done to reduce your risk for Alzheimer's disease?
Yes.
Oh, and so then I'll also add in, even when you're thinking about family history. So family history is not a definitive diagnosis. And then also when thinking about someone who has those genetic risks. So with the lipoprotein or that ApoE4 is a gene or allele that's been shown to increase someone's risk for Alzheimer's disease. You don't see that risk doesn't show up the same in all groups. So that's not a definitive diagnosis either. We use the ApoE4 genotype when trying to risk stratify someone for the newer medications, because individuals who have 2 copies of the ApoE4 alleles were at an increased risk for brain bleeds with the monoclonal antibodies. So we wouldn't recommend the medication. With the phosphorylated tau biomarker, we don't recommend individuals just get that biomarker just because you have a strong family history, because if you're not presenting with memory loss, you wouldn't be able to be treated with a newer medication, because it's only indicated for individuals with mild cognitive impairment or early stages of dementia. So say someone has the biomarker, which has happened a couple of times. So get the blood test. They have positive amyloid, a positive amyloid PET scan. Does that mean that individual has Alzheimer's disease? No, because they're not presented with memory loss. We can't definitively say because you have those positive biomarkers that you're going to develop Alzheimer's disease later on in life. They may or may not. You have individuals who have positive biomarkers who never go on to develop Alzheimer's disease. So that's why we don't recommend just getting those biomarkers done early, just because of family history, because it creates a lot of stress and worry for individuals.
What about sleep? You said that our brains get rid of the toxins when we sleep. What if you don't get enough sleep?
Then you're having that accumulation, and sleep impacts memory and your thinking abilities and focus and your attention. So not getting good quality rest is not good for you.
So if you get more sleep, it increases the goodness of your brain.
Oh, that ties into the question I think that was presented. What is healthy living or aging healthy? So getting good rest, exercising, brain healthy food, stimulating activities, making sure we're keeping up with our numbers, so optimizing our health, blood pressure, cholesterol, blood sugar, sleeping well. That's healthy aging, where you're doing all you can to help slow down any progression, because you do have individuals who are super agers, where you would think they would have cognitive decline, but they're compensating very well because they're still learning new information, challenging their brain regularly, getting good rest, and exercising. So we advocate for living your best life, even in your 90s, even if you make it to your 100s. We still advocate for living your best life and continuing to challenge your brain.
It seems like when you get older, you get insomnia more too.
Yes, you can. And if you have cognitive impairment, that can impact your quality of sleep as well.
And how does it affect the brain if you take a lot of sleeping pills so you can get the good sleep?
Sleeping pills are not good because some sleeping pills, especially like Benadryl or any PM medications or Tylenol PM, Advil PM, because they contain Benadryl or diphenhydramine. So they have those anticholinergic properties, which can be sedating, can also increase your risk for falling. So it can make you confused.
But they let you sleep. It's like what?
Yeah, that one.
Balance between them.
Right, you would rather someone get sleep, but you want you to get sleep by taking something a little more safer than Benadryl.
Is trazodone one of them?
Trazodone is one we prescribe. We typically start with melatonin first to see if you get any benefit from melatonin, and then if not, possibly trazodone, because you have that fall risk component as well with Benadryl. Which wouldn't be good, because if you fall, hit your head, and then you have the traumatic brain injury, which can impact what's going on. Or you can fracture your hip, which causes an individual to slow down. Oh, The other question, how would you rate your health? So I just asked that question because what they found was individuals who rate their health as good are twice as satisfied with life. So I just want you to be satisfied and just try to do as best you can to have your best quality of life.
Better than the alternative.
Any other questions for me?
Could you sum up a little bit about the studies going on at the university? My husband was in one for 8 years, Alzheimer's study at the UW.
Are you talking about the core studies that they have going on? I know we have newer studies. I actually brought one handout on a brain waste study that they have going on now. And I think they're still enrolling individuals. So MRI, a brain waste clearance study. The purpose is to collect brain scans and blood samples to provide information about your brain's waste clearance system. And it's anyone 55 years of age and older. But you have to be diagnosed with mild cognitive impairment or mild dementia and then be able to have an MRI scan with this one. Now they do have their core study. So with our Alzheimer's Disease Research Center, you have your core study where you're monitoring. They've been monitoring individuals for several years and doing cognitive screens and imaging studies to see how individuals progress over the years. We do have, trying to think if it's, because we get updates now on open studies that's available. I printed out this handout for one. We have a study that's supposed to be coming out in the future, another study to target Alzheimer's disease, but that one hasn't started yet. I know we have an AHEAD clinical trial, but that's a closed study now. The AHEAD clinical trial is with the newer monoclonal antibody, where they're trying to get ahead of Alzheimer's disease, so those participants don't have a diagnosis of dementia at this time, but they have those positive biomarkers, and they're being treated with the medication or placebo to see how they do over the course of 4 years with the medication to see if you stop the progression of Alzheimer's disease.
What about the CPAP machine to help you sleep?
If you have sleep apnea, would definitely recommend making sure you wear your CPAP regularly, because the concern is with sleep apnea, that individual is dropping their oxygen saturation level below normal. So that's just repeated injury to those brain cells over time. So vascular disease, untreated sleep apnea can increase your risk for, as well as Alzheimer's disease. So definitely important. And we can see improvements in individuals who have untreated sleep apnea when they present to clinic. They typically impact their learning of new information more than your short-term memory. And so we can see when someone comes for testing before being treated versus once they're treated, they actually improve in their learning. And it's because of the untreated sleep apnea.
Is there any research being done, anything about GLP-1 drugs and Alzheimer's?
Not at UW, not at this time. They are. You do hear a lot where they say it may help with memory. We don't have any open studies currently on that research.
What was the question?
Oh, sorry. He asked if there's any open studies with GLP-1 and its impact on memory.
What's GOP?
I'm sorry. That's one of the newer diabetic medications that a lot of people are being started on, where they're saying how they help with a lot of things. So from a cardiovascular standpoint, kidney function, helps control diabetes, helps with weight loss as well in some individuals.
So you're saying there's no information, the correlation between the two?
He asked if we have any open studies looking to see if GLP helps with memory loss. Ideally, so you would say you have that secondary benefit if it helps to optimize blood sugars, healthier weight, and cardiovascular health. But that direct interaction, not sure of right now.
Is that an injection?
Mm-hmm. It is.
Like you show on TV?
Mm-hmm.
very popular now.
Mm-hmm.
Any other questions or concerns?
I saw you had traumatic brain injury on there as a cause, and is that reversible?
No, because it's damage to those brain cells.
They can't regenerate.
Unfortunately. Question?
Yes, I'm trying to really tell us a little bit about all of this knowledge that you've shown us, and where did some of that study come from?
Could you repeat?
The work that you're doing now, and the showing of all of the work about the brains and everything else, where did that study come from?
Are you referring specifically to AA fame?
I'm talking to you about it, and I want you to hear it. I want to hear it. Yes, I do.
Also, a lot of the data and what we're finding in the research side, so African Americans fighting against Alzheimer's disease in midlife, so that's a large sample size we have. The data that we get from those studies is what helps us on the clinical side. And so that's why I like being involved in research as well as on the clinical side, because I can see the impact of what they do on the research side, how it helps us in clinic. But then also on the clinical side, you come up with questions which help you come up with new discoveries as well. But the AA fame is a huge study that's helped with a lot of significant advances, especially with biomarker for one. The biomarker is very big. So thanks for all the research that they do in regards to biomarkers. Now we have a blood test that we can use in clinic to see if it's concerns for amyloid plaques in the brain.
And some of the people that you know in that study, that started that study, has moved on, of course. And the new system of what the name is now. Because I'm familiar with the Gleason lab study. And that's the study that pretty much some of the things that you're seeing and hearing now came from, which you were part of it when you first started a long time ago.
Mm-hmm.
And it's a lot of history that you bring. So I am grateful for you.
Thank you. Thank you. Any other questions or concerns?
I would like to say one other thing. I appreciate your time. And if anyone does have a couple more minutes, if you wouldn't mind completing a survey just to help me know what helped the most or what you like or didn't like about today's discussion, because then that can help me adjust the information as well. And I have those resources too on the Mind Diet if you're interested.
Okay,